these meetings. I've been in a few online groups for a few years, and this was one of them, and learned a lot from the group, and I'm pleased to say that we've got him to speak today. So he is the Associate Professor of Pediatrics and Emergency Medicine, all the way from Sean Jenkins Children's Hospital in South Carolina. So Matt, you can take it away.
Great. Yeah, and I certainly first thanks for having me. And I can definitely understand the wards being crazy. When I checked our board this morning, I think our 19-bed unit had 15 inpatients in it, so I'm not particularly looking to go into work later today.
Yeah.
I'm gonna go ahead and share my screen. Try and get this visible the right way. Is that showing and in the correct view for people? Yep. Okay.
Yeah, we can see it.
All right, great. So Dave and I chat a little bit about kind of what to cover. This we landed on going over some regional anesthesia techniques. This is designed to be, feel free to interrupt whatever this is meant to be, starting from more of a kind of an early kind of entry-level block format, covering just general principles and then going into a few specific blocks. If we have time, we can jump into a little more advanced stuff. But my understanding from the kind of the group was that this would be more in line with what everybody would want to hear about. So we're going to discuss some ultrasound-guided regional anesthesia. So overview, what I want to go over is a quick bit of background, touch on the indications and contraindications, look at complications in management, recognizing that you should know what you could encounter that is bad and how to manage it before you should go down the road of actually doing these. Looking at the logistics of doing blocks, and then focus specifically on some of the distal upper extremity blocks, and then end with the posterior tibial block. And if we have time, we can roll into some more proximal field-based blocks, specifically the fascia iliaca. So some general background, and this is going to be very quick. Regional anesthesia allows you to have multimodal pain management, can reduce narcotic usage, reduce sedation, and really kind of rounds out pain care for your patients. It's something that we find in general, the pediatric world is far behind the adult world. It is a core component of general EM practice, and overall ultrasound guidance within regional anesthesia has been shown to improve block success, efficiency, and reducing complications. This is a policy statement that came out in 2021 from the American College of Emergency Physicians, which is the US-based kind of EM guiding body, which basically stated in very black and white, sort of, no hold barred language that regional anesthesia is part of the primary practice within EM and really should be something that all, general EM providers are able to do. This has not made its way as definitively into the PEDS emergency medicine practice, at least on the state side, but it's certainly something that we're looking and seeing more and more from expansion-wise. This was a quick study that looked and kind of surveyed different EM programs across the US to see which blocks how many of them were using blocks, what they're using them for, and what blocks they were using. And what you can see sort of is, really they're using from any sort of like pain management, particular fractures, lac repairs, dislocations. And the things that were most commonly used are going to be, very straightforward: forearms, femoral nerve, posterior tibial making up, and fascia iliaca, which essentially is sort of your femoral, being the most common ones across the EM practice. Then you go into, more and more complex, typically core blocks, larger fields, larger complications, and less common use overall. Did I just disappear?
You're still there, but there's a screen. Yeah, you're back.
Okay. Weird.
You're back.
There's lots of adult data looking at nerve blocks, lots of it for like hip fractures and femur fractures, growing numbers of data on the PED side, some early studies looking at femur fractures within PEDS emergency medicine. We just recently completed a multi-site that was across the US as well as Australia looking at this, which we're hoping to have published soon, to try to get some like really like true robust data to show what we already know, which is that nerve blocks are beneficial. Throughout the data that has been published, nerve blocks show you that you have improved pain scores, decreased narcotic use, and no adverse events, and sort of no serious adverse events across EM ultrasound guided nerve block practice. And there was the recent, I believe it was JAMA, that just came out from the adult registry that kind of reinforced these same findings. So we switch gears to looking at why you'd want to do blocks. Really, your indication is going to be anything you have to do that's painful, whether that's pain control alone or for facilitating some sort of painful procedure. So lac repairs, fractures, dislocations, INDs, burns, foreign body removals, really anything that's painful, you can use a nerve block for it. The contraindications for this, some of these are absolute, some of these more are sort of site specific and maybe patient by patient. So obviously having an allergy to your anesthetic shouldn't do that. Anticoagulation, which is not something we see, near as often in the PEDS world as we do in the EM world, is a relative contraindication. I think certainly if you're doing like a small volume distal block, you're probably fine to proceed with that. Any sort of pre-existing nerve injury or neuropathy is going to make it challenging to know if you're having a complication with your block, so we generally avoid in those. Patients who are non-responsive and nonverbal, we generally speaking don't block. I will say you will see plenty of places that will actually sedate patients to put a block in. And this is often the practice within the anesthesia world where they'll be doing blocks on patients who are unconscious. So again, that's sort of a balance of what you want your practice to be. The downside for that is that you can't tell immediately if you're having a complication with your block from the nerve itself, if your patient can't tell you what's going on. Infection at your injection site, that's a fairly universal contraindication for sticking a needle in something. And then we generally avoid any patients who have hardware at the site that we'd want to be doing the block. The anatomy is going to be altered, and you don't want to risk infecting the hardware. Again, a lot of these are not particularly common in the pediatric world, far more common in the adult world. The complications you can see with nerve blocks are really, for the most part, similar to what you have with other procedures. So bleeding, infection, local tissue injury, all common anytime you can, or all at risk anytime that you are sort of inserting something in the body, allergic reaction to the anesthetic, nerve injury, and then local anesthetic systemic toxicity are our sort of biggest concern. The overall incidence of complications in blocks is less than 1%. The ones that are really more true block specific, so nerve injury incidence is well below 1%, less than 0.04% overall reported lit. That nerve injury can occur from a variety of methods, whether you actually physically damage the nerve from the needle, whether there's pressure from the local infiltrate, whether you take out the vasculature, or there's some sort of like chemical response. If you have nerve injury, the management for the most part is just supportive and giving it time, and in most cases, things are going to recover on their own. We obviously want to look to see if there's anything you're doing that can cause it, i.e. if there's a needle in the nerve, pull the needle out. Minor complications will mostly improve, and then if you have long-term stuff that isn't improving, then ultimately you're looking at EMG studies and referrals. Last, or local anesthetic systemic toxicity is the biggest thing you need to be worried about. This is super, super rare. And in the world of ultrasound guidance, really should largely not be happening if you're following correct protocols and visualizing your needle as you do it. Last can be very nonspecific, but it can also be very serious with very major CNS and cardiac symptoms that go all the way down to seizures, arrhythmias, and arrest. Management of last is first and foremost stop injection. All right, this is occurring from systemic uptake of your anesthetic, so you want to stop putting anything in, supportive care for whatever symptoms you're seeing, and then it's going down the symptom-specific management, so anti-epileptics, you're having seizures, life support, drips, that sort of thing, and then ultimately your big ticket treatment is going to be intralipid, and we make a point of having intralipid bedside anytime we're doing a large volume block. I would say for the blocks that I'm going to be discussing today, we have it in our unit, but I don't make a point of having it out because it's usually much smaller volume. Keys to avoiding complications, first and foremost, know what your needle tip is at all times. The benefit of ultrasound guidance, again, is where your needle, you should know where your needle is, where you want it to be and where you don't want it to be. You should still aspirate before you inject the same way you should be doing if you weren't doing ultrasound guidance. Always sort of use a minimal volume, appropriate concentrations, and reduce your injection rate in highly vascular regions, because again, this is a systemic uptake issue. And then know your max dose and reduce in special populations. So know how the anesthetic you're using is being cleared. And if you have patients who have some sort of renal liver dysfunction that might alter the clearance of the anesthetic you're planning, make sure you adjust accordingly. All right, switching gears to looking at the logistics of doing blocks. So we'll discuss supplies, needle selection, anesthetic choice, monitoring, and then how we document. So from supply-wise, I like to keep kits, and I've actually been building a nerve cart, which I need to actually is on my to-do list to get officially in service so that we have all the gear handy. You're basically going to need things to clean off the skin. You can use a variety of sterile sort of field prep depending on your institutional practice, and I think this varies quite a bit, anywhere from just a simple like cleaned probe and quick chlor prep to the site, all the way to full sterile field with sterile probe cover and sterile gloves. I think that again is a very site-specific practice, and also should vary based on kind of the complexity, depth of your block, and whether or not you're going to be putting a catheter in, which is a much higher level issue. You need a syringe for your anesthetic agent. You need to pick your needle, and there's a couple different options there, and then you obviously need your ultrasound probe. And like I said, I usually package these all into little kits. So currently I have them in these so my providers can grab them. They've got everything in them but sterile gloves that they can go right in to minimize all like the running around to find gear. Couple different needle types you can be using. There's your sort of sharp cutting needles, typical like hypodermic needles, or your blunt needles are kind of your two main classifications. And then there within the blunt needle groups, there's also ultrasound specific ones. There are these echogenic needles that have these little laser cut etches on them to make your needle show better under ultrasound. I tend to use the cutting kind of smaller gauge, like a 27 gauge hypodermic if I'm doing a simple distal extremity block. And I'll use my blunt sort of echogenic needles when I'm doing more proximal, deeper field blocks. Here's what that echogenic needle looks like. It's going to have, a tube going to your syringe. This case, this is a stimulant needle, so this goes to an electrical stimulator we can actually use for nerve stimulation. And then you can see as you run down the length of this needle, you've got these little black marks, which are depth markings. And if you pay attention, particularly down here, you can see these little etches at the end of the needle. And these are those laser etches that really help you show well where your needle is on ultrasound. Sort of needle gripping and sort of setup. If you're using a block needle, these are going to be connected to a tube. So you're typically going to need a second set of hands to do these well. I definitely have some of my EM colleagues which will manage to hold the syringe within the needle hand as well. It just creates for more like dexterity to manage it. One hand on the probe, one hand on the needle. The benefit in the forearm ones using the hypodermics that are connected directly to syringe is that you can have control of the needle and the syringe all in one hand, so that you can have this as a single provider. From a local anesthetic selection, you've got a variety of options. This again is going to be formulary based. And I don't know, kind of labeling in the UK if you guys have different ones that we do. We typically have these three, so lidocaine, ropivacaine, bupivacaine. You can think of these as different onset of duration, different timing of onset, different duration, and then varying toxicity risk is shown here with the different max doses. I typically think of these as sort of short, medium, and long. We in my shop use lidocaine and ropivacaine. We typically avoid bupivacaine because it's got a little higher side effect profile. Again, I think a lot of this is going to be you're going to be beholden to what your pharmacy stocks. I think they're all worthwhile potentially for use. The other things to keep in mind when you're doing these is that you may have additives like epinephrine and dexamethasone or Precedex to them, which may prolong block duration. I think that's an area of a lot of ongoing and really interesting research to see how we can take the block we're doing and making more robust. The other thing to keep in mind when you're doing these is that, you have the med, but there's also varying concentrations for each one of these. And definitely knowing what percentage concentration you have in your supply is important because, your volume dosing is going to be dependent on that. And you can very easily make a whoopsie if you think you have, say a 0.2% ropivacaine, you've got a 0.5% instead. Monitors, I will say when I'm doing a distal like extremity block, I don't necessarily have patients on monitors. If you're going to be doing something that's more proximal and larger volume, you should definitely have your patients on monitors. And this should really be kind of full cardiopulmonary monitors. So with EKG leads, oximetry, blood pressure running, and really should monitor them, throughout the block. And then we typically monitor for 30 minutes after. And this is to help give you a sense of any of those side effects, in particular signs of blast with arrhythmias and that sort of things occurring. From a logistical setup, anytime you're setting up for a block, you want to think of it as the same, sort of optimizing the ergonomics you're going to be doing with any other procedure. And the key for me is I really want to have a clean line of sight from my provider through my procedural area to my ultrasound machine so that all of those are in one space because I'm typically going to be doing these in plane. And whether you're doing in plane or out of plane for that matter, the cleaner your eyes are from your hands to your the body part that you're working to your machine, the better this is going to be from an ergonomic standpoint. And so here's a couple examples. This is one of my fellows doing a block on my posterior tibial where we've got the machine sitting here. I'm positioned sort of my side and she's got the probe and all of her vision is be able to sit right through there. And similarly, one of my fellows blocking my forearm, again, kind of clean line of sight from their body, the area they're blocking, and then the machine kind of all in one big view. We typically do consents for these. This is going to be site specific, and I don't know kind of the practice in the UK. Certainly in an EM department, if somebody's coming in for a big wound, there's some degree of implied consent, whether you do just certainly should go over the verbal consent options for these, particularly the kids, because this is going to be one option of many for pain control. But we typically do a full written consent for these, which I just keep pre-printed and stocked, with all the nerve block specific things and have it sort of for efficiency. So my providers can just grab one that's already ready to go. From a documentation standpoint, we do a couple different options. Again, this is going to be site specific based on your EMR. I think the key is documenting the details of your block and doing it in real time because, nerve blocks are one of the few procedures that somebody else may come behind you, depending on the patient, and do the same thing later on. So if you're blocking a patient in the ED and they're going to be admitted for further, management, it may be something that anesthesia, your block is going to eventually wear off. And if you've got something that's going to be happening operative in the same area, your anesthesiologist may come along and do the same block. And last thing you want to do is have it poorly documented, and there's no mark on the patient except for maybe a small Band-Aid. And then somebody comes, does a block within the window that your anesthetic's still active. And then you end up with problems from a system dosing wise. We do quality assurance forms on all our patients. Again, this is sort of just more of kind of a our PEDS practice since we're newer into this from the PEDS world. Collect some patient information so we can contact them, usually within a day or two after the block, just to find out how they're doing, how long they think the block lasted, and if there were any side effects going on. So transitioning to the actual steps of the block, we already talked about consent, documentation, the QA. So now we're going to focus on the actual block itself. Big steps there: find your nerve, guide the needle to the nerve, and deposit your anesthetic. And this is really going to be universal for any block you're going to be doing. So for the start of this, we're just going to do distal upper extremity. This is a great place to start. They're very straightforward, really low risk. There's no major injury you're going to do. There's no organs. You're not going to give somebody a pneumo by going, hitting someone in the core. And so a great place to start, and there's lots of indications for them. So anytime you're doing a block, you know, the relative anatomy that you want to block, which is just key to know the dermatomes. So the skin innervation of the nerves you're after, and classic dermatomes here for the forearm, the radial, median, ulnar nerves. The other key to note is that, depending if you're doing soft tissue, then your dermatomes. If you're doing blocks for bony injury, then your bony injury or dislocation, the osteotome distribution. And these are similar dermatomes, but they're not necessarily exactly the same. And the other key to know for any of the osteomes is basically every bone is going to have at least two nerves innervating, if not more. So anytime you're doing fracture management, you're often going to have to take out more than one nerve to get really high level anesthesia. Certainly taking out one of them will often help, but it may not give you, complete anesthesia for what you're after. The other key I always point out to people is that while your dermatomes, we all learn these in our classic anatomy textbooks, have these nice demarcated lines. I find very rarely is there a procedure that I'm going to do that only one nerve in the forearm is going to be adequate, because while these are, this way there's cross innervation amongst dermatomes. And so usually I'm going to take out, the area that is the most focal and then probably one of the other adjoining nerves, anticipating there's going to be some cross innervation there. So we'll focus to start on this on the median nerve. So median nerve innervating the palm of the hand for the most part. So common injuries to there. In this case, we've got patients was running up the stairs with their keys, fell, landed on the keys, and sort of impaled them within their hand. So first, we're going to find our nerve. So here, always going to use a linear probe for these. It's going to be shallow. You want your highest resolution possibility. Median nerve is going to be mid-forearm. I typically will find all of my nerves or try to find them in the distal wrist, right at the crease of the hand, and then track them proximally up the arm. The key with that tracking is that the nerve and the tendons within the wrist often look pretty similar. And so tracking them helps you differentiate, nerve will stay fairly consistent in appearance and will often, as you come up, separate itself out from those tendons, whereas the tendons distally will look like tendons, and as you move proximally, they'll transition into more muscle tissue and go through the aponeuroses, and then you can kind of differentiate the two. So here we've got a video of that tracking. So starting at the distal wrist, linear probe, you can see what we have circled here is currently the median nerve, but if you look around it, there's a bunch of other structures that look pretty similar. If you had your patient wiggle the fingers, you might notice that some of these move and the nerve doesn't. But as you sort of track yourself up, you note that the object that you were looking at, it is the nerve, moves itself along, continues to stay very much in that sort of same overall shape and size, whereas a lot of these under tendinous structures end up getting more kind of dissolving out into muscle tissue. So median nerve is going to live between all your nerves, which are going to be living within, tissue planes. So your median nerve is going to be between the flexor digitorum superficialis and the flexor digitorum profundus. It's probably the easiest one to find in the forearm. Here it is sitting in sort of real anatomic area outlined with those two muscles. You can see it here. It has this classic honeycomb shape, so hyperechoic with like mini hypoechoic circles throughout, sitting in this tissue plane here. Keys to sort of other note here, which may or may not be showing up well in this image, is that, your median nerve is running right down the middle of the forearm. The other nerves that are going to be relevant within the forearm are going to be your ulnar to the ulnar side and radial to the radial side. And so those you want to make sure you can identify. In this case, we can see the sort of ulnar, the ulnar artery and nerve are popping in there on the side there, because those are going to be relevant when you think about your needle approach. You do want to be aware, most people don't have vasculature running with their median nerve. However, some people, myself included, have fairly prominent neurovascular structure with an artery and a vein running in there. And so you want to make sure you look for that. I'd always throw color Doppler on before you're going to be poking anything, just to make sure you don't have some obvious vascular structure. If you have someone who has this would obviously inform the direction that you want to come at this nerve. You want to avoid the artery side and be coming at it from this side of the forearm. So here we have kind of scanning along again in that forearm here. You can see those muscles and the nerve sitting in there. You can watch as that nerve kind of changes tissue planes. Really the goal of fanning along as you do any of these nerve blocks, and this is going to be forearm or anywhere else, is to help you feel good about the nerve, that you know exactly what it is. Is that back to sharing? Okay. So the goal of this panning is to make sure that you feel confident you can see the nerve, and in fact, that is the nerve, and then that it's separating itself out from any sort of obstacles around you. Median nerve, again, not too many obstacles for the most part. The other nerves are going to have more to worry about. The echogenicity of your nerve, we already talked about, has this sort of classic honeycomb appearance when you look at it distally with these sort of small kind of nerve bundles with connective tissue around them. As you get more proximal, what you will find is that there's going to be more nerve tissue and less connective tissue, and that's really that connective tissue that is the hyperechoic. And so as you track nerves higher up, and usually this isn't occurring in the forearm, this is getting kind of elbow up, you'll see they go from this honeycomb appearance to almost looking like vessels. If you've ever looked at like brachial plexus, or if you track, and I've got some images of it, the radial nerve above the elbow, which is where I often like to block it, you'll see it transitions fairly abruptly from this honeycomb appearance to looking almost like a vessel. And that's just that transition from these kind of nerves going from these finer branches to their kind of deeper core nerves. Another key component when you're visualizing nerves is the concept of anisotropy. So this is relevant to any kind of ultrasound that's highly reflective service. So your nerves with all that connective tissue are highly reflective. And so as you image the nerve in a nice, perfect perpendicular to the nerve, you will see it well. And as you come off axis to the nerve and image it more in an oblique plane, you're going to see much poorer visualization. And that, again, is just due to that angle of inclination, whereas if you hit it perfectly perpendicular, your sound waves are going to hit it, come back, reflected right back to your probe, which is your off axis. They're going to reflect off, and you're going to lose image quality. The big thing with this when you're doing nerve blocks is that once you've found that nerve and you get that really optimal image, you really want to have your probe hand locked down on that spot so it's stable with the probe and the part of the body that you're going to be viewing. So there's going to be as minimal movement on that as possible. Because what you don't want to do is find a good view of the nerve, go to insert your needle, and then you go fanning off with your probe to find the needle, and then you lose vision of your nerve. So you want to keep the probe as still as you can once you found it. So once you find your needle, you got to guide your once you find the nerve, you got to guide your needle to it. You've got two main options anytime you're doing ultrasound procedures. You've got your in-plane and out-of-plane approaches. I tend to do in-plane for all of my nerve blocks. I tend to do out-of-plane for all my vascular access. You can do both for either option. It's really kind of provide a preference. I find with the nerve blocks, I've got a stationary object that I'm after. I'm not trying to feed the needle into a lumen. I'm just getting it to a target. So I like to be able to see it coming in the entire time. And usually I can get myself positioned to where all of my obstacles are that I have a clean path for in plane, but there are definitely cases where you might have to do an out of plane. So here's visualization of that. So again, we think we saw this photo before. This is one of my fellows doing a forearm block on me. You can see she's got her hand here coming in. Probe is long axis in line with the needle, and the machine is going to be over here. This is what it looks like to do an out of plane approach. This is actually me blocking my own saphenous nerve in conference one day. This is one where you don't really see the nerve well, and it's just going to localize right next to the vessel. So dumping a bunch of anesthetic right near the vessel basically takes out the nerve itself. But there's certainly roles for either one of these. Anytime you're doing in plane, right, you've got a bunch of different angles you'd be coming off of, anywhere from right off the probe until way away from it. Keep in mind that that same angle of inclination that is relevant for the nerve is also relevant for the needle. And so as perpendicular as you can be to the probe with your needle, the better you're going to see the needle itself. The key to keep in mind is what is the sort of obstacles in your way? Do you have bone in the way? Do you have vessels in the way? In this case, option C would be our best. But if you're thinking about the forearm, you're also going to have the ulnar and radial vasculature and nerves coming in. So you want to make sure you've identified those so that your angle you're coming through with the median doesn't take out one of those in the process. Here we have that again, fairly idealized, pretty perpendicular approach with the needle coming in line with your probe. So once you've got it lined up, you know where you're going to come in. right? The goal is to just guide that needle straight in. And really my target is usually just below and ideally just a little past my nerve, especially when I'm doing the hypodermic needles. The reason that being is that these needles are going to have a little bit of sort of a fire hose effect. And as you start injecting, they're often going to push your needle out a little bit. And so I like to be a little past if I can. So if they push me back, I'm sort of right where I want to be. The other key to keep in mind with these is that we're talking, specific nerve, like individual nerve blocks versus more of a plain block, is that we'll talk about putting anesthetic right near the nerve itself. And in reality, all of these individual nerves are still sitting in those fascial planes. So this nerve itself, you can kind of see this fascial plane between the muscle. And so even if you actually hit this further away right in that fascial plane, you'd be able to see your fluid dissect in and around the nerve. You hit that plane just right, which is the same concept we're doing for a lot of the more proximal field blocks. So here you got the anatomy and the nerve. Needle's going to be coming in from screen left. Goal with this is always knowing where your needle tip is, right? Any ultrasound guided procedure, you really should not be advancing the needle unless you can see the tip well. And we're walking it to the nerve. And again, most of the time I'd try to march it just past, inject, and then let myself flow in through here. Once you've got the needle there, deposit your anesthetic. Again, steps when you're doing that, you've already visualized the needle where it should be, and that's where you want it to be, and most importantly, that it's not in a vessel. You should still aspirate with ultrasound guidance. The importance for that is honestly probably less than it is when you don't have the visualization with ultrasound. And then inject your anesthetic in slow increments. It should be around the nerve, not in the nerve, and observing spread around the target. So we got those muscles again, needle coming in. Guiding it just past, right now we're right at the nerve itself, starting to deposit anesthetic. You can see that hypocoag collection working around the nerve. Provider here is getting pretty close. You don't probably have to be that close, honestly. And then eventually they're going to work their way past that. And you can see that anesthetic, once you get under it, really guides around the nerve. And I think in the back end of this, they actually try to work themselves above the nerve to try to get like a 360 surrounding spread. I don't honestly usually bother to do that. If I've got this nice kind of 180 of anesthetic around the nerve, that's going to bathe the nerve well and give you a nice dense block. So definitely inject around the nerve, not in the nerve. Things to avoid here. You'll see providers coming with a needle and you can watch that nerve and they're just popping that nerve, right? That does not feel good. Your patient, if they're awake, will probably tell you immediately that does not feel good and they're getting shooting pains down their arm. You definitely don't want to inject in there. Other things to try to avoid. So here the provider is starting at the top of the nerve. And so you can see the nerve is here. They've come in at top. And in their injection, they're putting in this hyperechoic lucency. So this is air that they're injecting. That's just a little residual within the needle. The downsides of coming in above the nerve are A, that you could put in air. B, if your anesthetic is going to push your nerve down a little bit versus if you're below it, it'll lift it up to you some. And so it makes it easier to do kind of ongoing manipulation if you need. One of the things you can do to avoid this air is just once you find your needle in the tissue sort of further away, you can do a quick little test injection to kind of clear your line. And ideally, you should have already cleared the line, but even when you do it before you inject, if you kind of clear it in the space around you, you still could get a little bit of air in there. So I will typically clear it before I put the needle in and then do a quick injection somewhere over here so that I'm not worried about putting air in when I get to it. Here's sort of a full span of this, someone coming in, cleaning, putting in our sterile gel, coming in this case, we've got just a tegaderm over the probe coming in, got our nerve here, muscle planes, needle coming in plane from this side, walking into. The other key to think about when you're doing your needle selection is these 20, especially if you're using this 27 gauge, you'll notice, they're making pretty big adjustments well away from the nerve. These needles are very thin and they bend very easily. So you really can't do much adjusting once you're well into the tissue. You've really got to be, if you get into here and you see that your trajectory of the needle is not where you want it to be, you're gonna have to back it out and angle outside the skin. Otherwise you think you're moving the needle and you're just bending it at the skin level. And then once your block is done, I will marker the site and sort of do the same way a surgeon will sort of initial a site that I've done a block and put a time on it. And then quickly do your procedural note. So that's in the system. If you have a consultant, you want to make sure they are aware of it so they don't do anything downstream that's going to be, compromising the block. Or in the case of you're doing a block for a consultant to do a procedure, that way they know kind of the time clock of when things have started, when you should be good from an onset, and when that might be wearing off. Questions or anything, feel free, please interject if anybody wants to add anything.
Yeah, Matt, I've got a few, if that's all right. Awesome talk so far, thank you. So the first one is, are you typically doing, blocks whereby other specialties are going to come in and perform the procedure more commonly, or would you say you're still maintaining that overall control and you're doing a lot of things yourself? Because I suspect that will differ a little bit from how things maybe are in the UK, and that we're increasingly, allowing other specialties to do the more involved things compared with maybe 10, 15, 20 years ago.
Yeah, I think I will say that I am more procedurally oriented, so I probably do more procedural stuff than a lot of my colleagues will. And I think that kind of goes with the ultrasound side of things. The people who feel more comfortable to guide a needle into a space are also going to be more comfortable doing other procedural stuff. It is definitely a dynamic with when you're talking about a subspecialist doing the procedural management. If you're doing blocks or the pain control for a subspecialist to do a procedure, I will say our site, we've had a lot of growing pains getting, particularly like really any of them, but like the orthopedists for one, to accept that we're going to do a block for their procedural management. Because they are concerned it's going to, lose their neurovascular or the new, lose their neuro exam because you've done a block. And their understanding of, honestly, like which, say, fractures are going to be at risk for compartment syndrome and stuff. They're just sort of spoiled in that. The other thing is that, from a pediatric balance, your patients, if you're blocking, means they're awake for the procedure, and our proceduralists are sort of spoiled and having kids asleep. So getting them to be away from full-on sedation has been a challenge too, and know that kid's going to know you're manipulating their fracture or whatever, because it doesn't give you the same, obviously, like, anxiolytic component. So that's sort of a growing, sort of an ongoing negotiation with them. Like I can say, the first time I breached with our orthopedist the idea of doing the fascia iliaca for our femur fractures, they were just hands down like, no. One quick email, no, we'll lose our neuro exam. And then the second time I did, all of a sudden they were like, how quick can we start? And it was just sort of changing practice and work that. But even though we got that one going, I had a teenager with a forearm fracture who we really didn't have the manpower to sedate. And I was like, I'll just do a brachial plexus on him. And the ortho was like, oh, no, I'll lose my neurovascular exam. I want him sedated. And, the sort of the irony of like, well, what's going to lose your neurovascular exam? Them being unconscious.
General anesthesia.
But like, so it's a running negotiation. My surgeons have been okay with me doing some field blocks for some like abscess INDs. But usually if I'm going to the trouble of blocking, then I'm just doing the procedure.
Okay, great work. And then my other comment was, are you literally the best sort of, fellowship director around? Because am I going to have to let my future fellows perform blocks on me? Because I think an ex-fellow's on the call and possibly next year's fellow might be on the call. So is this the standard?
So I get poked a lot. My fellows all do now what I do. They used to do so when I'm doing this subject with them, they all do a hypodermic in my forearm, and then they all do a nerve block needle in my radial above the elbow. And then any of them who are interested, I offer up my femoral nerve for a fascia iliaca. I also get IVs in a lot. I'm running an IV course later today, and I'll have probably 6+ IVs done by the time the day is over. So I just find, all of the sim models and stuff we can build are useful, but until you've done it, and I'd much rather them do it on me, until I get nerve palsies or start getting, DVTs or endocarditis. I will say one of my ultrasound fellows before did my brachial plexus once. I'm a little more lenient to do that, a little more hesitant to do that, because that was definitely one of those, like, I lost my needle, and I'd be like, bow, yep, I'm like, you can see my arm jump. I'm like, there it is. So I don't think you have to.
Okay.
So going back to these, radial nerve, again, different dermatomal distribution, same general concept though. Find the nerve, guide your needle to the nerve, deposit your anesthetic. Radial nerve, the way to find the radial nerve is to start at the wrist, find the radial artery, and the nerve should be radial, so more to the kind of the thumb side than the artery itself. Radial for me is often the hardest to find in the forearm because it's just small and doesn't necessarily jump out. It should be sitting again within a fascial plane with the vessel, and then in these muscle groups. Here you have it there, kind of in the actual anatomy and marked. And so smaller often hides in the hyperechoic connective tissue. And this is another one we're just fanning along in the areas. So here we're coming around, if you watch medians here, arteries here, nerve is here. As you go more distal, they're going to be merging together. And as you go more proximal, they hopefully separate out. And every person's anatomy is different. And this is going to kind of be moving target. And really, it's, again, a matter of going up and down the forearm, kind of keeping an eye on the artery, looking for that hyperechoic nerve to sort of pop out in a way that you feel comfortable saying, yep, that is the nerve. and it's in a plane where you can get at it. So here we have, once we found it, again, vessel, nerve, going to be coming in from the thumb side. Again, guiding your needle into the nerve, just under it in an ideal fashion, depositing anesthetic. Again, keep in mind, the other thing I like to think about with the forearm nerves is that even if you don't feel like super great about, I'm definitely sure that's the nerve, it's going to be in this tissue plane. So even if you're not definitive there, if you get one of these tissue planes around and get the anesthetic in the general area, it's probably going to be fine. If you think about the old school anatomic of like, where we'd like find the pulse and go just a little lateral to it, or for like median, make somebody flex their wrist and find those couple of tendons that pop up and then going between those, right? Ultrasound's already giving you a lot more information than you had by just an anatomic approach. Another block here. So radius actually sitting here, needle coming in. And again, artery, nerve, and you can see you've got these sort of tissue planes on the muscle. And so initial injection there, you get this kind of like pillowy appearance of the anesthetic being in the muscle plane, past the nerve, and as you walk back through it, coming into it, you can see that anesthetic now starting to dump around the nerve. And here in the back end of this one, they're going to adjust the needle a little bit and actually come in a little higher and hit this tissue plane. And when you see hit that plane, it really unzips around the nerve. And that's that same concept of doing like more of like a fascial plane block as you hit that potential space around the nerve. The other approach you can do for the radial, which I will say a lot of times in the forearm, the radial just doesn't jump out well, is to come and do it above the elbow. Once you get above the elbow, you can track it. The radial nerve is going to run in the humeral groove if you get too proximal, but typically kind of right above the elbow. This is a shot from Highland. Highland is a great resource if you're wanting like for your nerve block resources, but it'll sit there and you can come in through the tricep. This is video on the right is my fellows blocking mine. So here's my radial above the elbow. And so they can come in through there. This is with a block needle, and this I just have them do because it's a different approach and different length. And what they say right now is they're injecting and they're getting little muscle injections, not really bathing the nerve well. And as they back up a little bit, they hit this fascial plane. And once they hit that plane again, that anesthetic starts spreading in and around the nerve and really starts to bathe it well. And so using those fascial planes lets you stay a little further away from the nerve and still get the job done well. Do keep in mind the one big thing if you're going to do the radial above the elbow is that you're going to get a wrist drop, whereas below the elbow typically won't. So know that as far as like what you're going to be sending your patient out to, most cases not going to be an issue. It also does give you a nice way to know that your block has worked. One of my adult colleagues one time did this, and the patient was just swearing up and down like, "Doc, it didn't work. It didn't work. I still feel everything." And then he's had him raise his hands and put him up like he was trying to stop traffic. And of course, the contralateral side, the palm is up in the sky, and the other side, he had that nice wrist drop. So he knew the block was doing what it was supposed to be doing, even though the patient was being very adult and belligerent. And then last for the forearm, ulnar nerve, again, going to be kind of, pinky side. I will say I don't do a lot of ulnar nerve just because the distribution is so small that, like if you're doing the pinky, you can also just do a digital block. It's also one that's pretty tricky to get at anatomically in the forearm because you really it's pretty well into the ulnar side. And so you often have your patient kind of have to torque their arm pretty good to be able to get an angle where you can approach it. Or if you have your patient sort of raise their arm up, like shown on the screen, right, that'll give a much more natural approach to the nerve. Again, sitting in that fascial plane with the vessel, and is going to be ulnar to the vessel itself. So vessel, nerve sitting there. I do find the ulnar is pretty easy to find most of the time. Again, fanning along, we've got our vessel, we've got our nerve, we've got the bony structure there. And as you fan along, you'll be able to see that nerve kind of slide in and out, get itself where it's really close to the vessel as you come more distal. And then as you get more proximal, to typically slide away and give yourself a nice clean shot where you can get it without getting the vessel in play. And then same thing with the block. Get yourself where you feel good about the nerve, get it where it's away from the vessel, come in, guide that needle into it, and do your block. So changing gears. So the last one I want to make sure to cover is if you're doing lower extremity. So again, different dermatomal coverage, different osteotomal coverage. The big thing here to note is that the vast majority of the sole of the foot is the posterior tibial nerve. And anybody's ever done a procedure on the bottom of the foot, like that skin is dense. It's really hard to inject local. It hurts, quite a bit to manipulate. And so being able to do a block that takes out the vast majority of the bottom of the foot is great. We are in a beach area, and so we have tons of kids that come in with plantar foot injuries, whether it's foreign cuts. We have a lot of oyster bed injuries, which are really nasty because they're easy to get infected. They leave bits of shrapnel in there, and you have to often do a lot of digging to find them. So the PT nerve is going to be great because it takes out so much of that tissue. This is a kid who's got a stingray barb in their foot, which are no fun to get out whatsoever. So PT, again, remember you feel the PT pulse. Nerve is going to be just with that, typically towards the Achilles side.
Matt, sorry, it might just be me, but we're still on the slide with the ulnar block. For me, anyways, anyone, it might be better for others, but for me, it's still stuck on halfway through the video for the ulnar.
Same here.
Yeah,
Okay.
I think same for
Same
a few
here.
people.
Still there?
Still stuck on that one, yeah.
About now.
Still on that one.
All right, let me stop sharing and try to reshare. How about now?
Yeah, that's it. Awesome.
Stop.
Okay, sweet. Sorry about that. So lower extremity again, key being again, like just how broad the posterior tibial distribution is. And so it's a great block for us in the pediatric world, kids running around barefoot all the time, getting all kinds of things impaled in their foot. In this case, we got a stingray barb. You know, this, and really almost all of the plantar foot is going to be innervated by the PT nerve. And so you can take out a ton of territory with one little block. Is it moving along now? Cool.
Yes.
All right, so nerve going to be to the Achilles. So if you think about where you just like palpate for a PT pulse right behind the medial malleolus, right? Artery is going to be there. Nerve is typically going to be just to the Achilles side of that spot. I will typically find the nerve at that level. Again, focusing on the neurovascular bundle, try to identify the nerve there, and then track myself up the leg to an area. Because if you imagine here, right, it's going to be hard to come in plane because you got bony structure and Achilles right here. You could try to come in out of plane right here, but if you go up the leg, then the bony stuff gets out of the way. You avoid the Achilles, and my goal is usually to get about a third of the way up the leg, so that I avoid the Achilles tendon itself and go through the muscle in a nice kind of 90-degree shot. So at the level of the ankle, here's your anatomy. You know, you sort of use mnemonics, sort of Tom, Dick, and very nervous Harry. So for the muscles, neurovascular bundle, and then muscle here. And your nerve is typically going to be sitting here. Again, this is, you know, ideal. This is not necessarily going to be every patient. Here is that same in an actual patient. You can see those muscles, the vessels here, and the nerve and the neurovascular bundle, and then the bony tibia sitting there. And again, that honeycomb structure there. Again, a lot of times nerves in a single shot just really don't jump out at you. It's that kind of dynamic scanning that really lets you see what you need to see. You watch those here as we start panning along, moving ourselves up and down within the ankle. You can kind of see that nerve sort of swinging around, the vessels move around a little bit, and you can ideally get yourself a place that's going to be more proximal to the point you get a nice clean line for your nerve to come in. This, if you move up further, and this realistically is probably a little bit further up the leg than this shot is showing, you'll now get the bony structures out of the way and get the Achilles out of the way, and now be able to go right through the soleus and ideally come in and get a nice clean shot right into that fascial plane with the nerve itself. Here those are from a labeled ultrasound and then sort of ultrasound image. And if we track this, so here we've got kind of posterior side, anterior side. We've got nerve sitting there with the vessels. This is distal, and then as we track ourselves proximal up, you can kind of watch that nerve sort of swing around, the vessels get themselves out of the way, you get more and more muscle on the backside towards the posterior side, and you end up in a nice spot, much more proximal, where you can imagine needle easily coming through here, aiming kind of right underneath this nerve, hitting this fascial plane, and having a nice needle trajectory for your injection. So here we have the block coming in, our nerve's there. You can see the pulsation of the artery to help you kind of know where that neurovascular bundle is. Again, needle coming in. There's this potential space of this fascial plane here. So really, you're going to punch through this and go just past it and inject through, guiding the needle to it. You know, here we're a little bit high. We're kind of coming in right at the nerve. I'm going to try to slowly manipulate down to get below it. Little kiss on the nerve there. We'll ideally probably avoid that. Subtle injection there, just right at the nerve, and you already see it starting to spread around. And then here you can see towards the back end, great view of the needle here, that reverberation artifact, big anesthetic volume around it. And this will give you a really nice dense block. I've done these on kids. I remember one where I was doing, it was a young boy who was like 7 with autism. So not necessarily someone who you think would be like a great block candidate, but we managed just a little bit of freezy spray right at the skin, got, you know, some child life to distract him and a little restraint on the leg to get the block in. And once we had the block in, child life was at the bed, you know, head of the bed with, you know, an iPad playing games with him. He had a needle in his foot that we went after, and mom, like while we're in procedures, like, will you let us know if when you start the procedure? And this was like I already had a hemostat like buried in the kid's foot, and he had no idea whatsoever. And so it was just fantastic. Saved a sedation. Really good for patients. So general take-home points from these. So nerve blocks decrease pain and opioid use. Ultrasound improves success and decreases complications. Know when to block and when not to block. Pick patients wisely, and that really kind of gets to like, especially in the pediatric world, like not every kid's going to hold still. And so it's a balance of who's going to hold still, what's your workflow and resources. I do think when early on, when you're getting nerve blocks going, especially for us, like my nurses know how to set up for a ketamine sedation real quick. Whereas like nerve blocks, sometimes it takes some time to collect the things and they don't really know what to set up or if they need to be involved or not. But once you get going with it, you get your supplies, get kits built, it can really facilitate the timing of that. And it's a lot of it's a culture change. Um, Set yourself up for success. Always want to have, again, that clean line of sight from an ergonomics, and always have your hand supported. So that needle hand really, both your probe hand should be in still on the body, and you really want your needle hand supported as well, whether it's, resting on something like the heel of your hand or having your sort of pinky down so that you control your needle. The more stability you have, the finer your movements are going to be. And then obviously knowing which blocks to do, know the dermatomes and osteotomes of relevance. Happy to take any questions. These are some resources that I like to sort of reference out to. Actually, sorry, this is an IV one that I left in from something out. Lots of different research out there for nerve blocks. Highland ultrasound is fantastic. It's like straight to the point. It's not a lot of fluff. It's a lot of visual stuff. Nysora goes much into the weeds on like the how-tos. Baby Blocks is a PED specific block site. This is the YouTube channel is the Duke Regional Anesthesia site. They've got a bunch of good videos. There's a bunch of good apps now. So Safe Local will help you know how much anesthetic you can do based on your anesthetic, the concentration, your patient's weight. And the Nerve Block app is a nice, like, here's the distribution, here's the block. This QR code will take you to the Holy City Sono site, which is my adult EM colleagues website. Basically the recorded version of this lecture, as well as a bunch of other sort of lectures that our group has built, are available on there for free to watch if you ever want to see this. Or I know we have like my IV lectures on there, and we're slowly getting more things uploaded. So lots of good resources out there. And then happy to take any questions. Looks like we're just in time here. I saw something. I'm going to stop that and look at the chat.
Yeah, nothing written in the chat. That was just about the slides. But I think there was a hand up earlier, but then it went down. Did that person still want to ask anything? Don't be shy if so. I was just looking at the app you recommended, Matt. I wasn't aware of that. So it's just the nerve block one. Black and yellow font. It looks really good. I've just got it here, so gonna give that a go. You can't see my camera, but
yeah, it's awesome. A very handy one, just kind of one of those like just-in-time reminders of like, okay, this is my area, what might work well, because you can pick region and it'll help you kind of walk through some stuff. Because ultimately, like this, like most other procedures, it's really is what's your target, what do you need to avoid, and then good needle control. And at that point, all the procedures are pretty much the same.
Awesome. Yeah, agree.
Somebody's got a hand up.
Yeah, sorry about interrupting. About the complications of the nerve blocks. I was doing a teaching session a couple of days ago with one of the juniors, and he accidentally, he injected into the nerve about 5 mils. So I couldn't find any sort of like background or any recommendations for how long to observe how long to observe the patient for the complications, or is it just the like recommended, like the same as the normal block? And because he injected directly into the nerve itself, is there any precautions that we have to do? Like after that, I can't find any sort of like direction to go on any of the resources about it.
Yeah, I mean, the monitoring as far as like real-time ED is really more about like systemic complication and like last. As far as like more like definitive like local nerve injury itself, that's really going to be like time will tell. There's not like you can't really do anything about it at that point. Like whether you've had mechanical or injury from the needle itself damaging the nerve, or injury from like pressure from the anesthetic kind of going into the nerve capsule and sort of just like pressuring the nerve. They may have nerve symptoms, be it pain, paresthesias, whatever. it's really just supportive in time. In most cases, the nerve's going to be fine, actually. But there's not much at that point from just a local nerve injury that you can do or really need to monitor, because sort of what has happened is happened.
Okay, thank you very much.
Dave, you had your hand up.
No, can you hear me? Yeah, we sort of covered it with that, actually. Yeah, I was just wondering specifically what had occurred in that scenario. But yeah, you want to keep your needle tip away from the nerve itself at all times. But your videos were excellent, Matt, showing the unzipping of the fascia and circumferentially coming round. So that was excellent CPD. I think, it's evident that you guys are doing a lot when I'm in these talks with you guys across the pond. And I think just for those of us who are going to develop skills in ultrasound and use it on the shop floor, we shouldn't be shy about extending those procedures and skills and beginning to do a little bit more, because I've started to do popliteal blocks and things like that. It is a slightly different system of healthcare, of course, but I think for those who are improving the skills and using ultrasound, doing it safely, I think we shouldn't be put off by all of this. So this has been brilliant for me, looking at the upper limb stuff, because I've been showing them a few times before, but I've never really had much of an opportunity to introduce them into practice. But I guess we're the new generation of people who are going to be doing that with ultrasound. So thank you.
Yeah, I think the nice thing, again, elbow and knee down, there's really not much you can harm, and you're doing small volumes. So realistically, even if you injected like right into a vessel, you probably would be fine. You're talking about like anti-arrhythmic dosing of lidocaine at that point. And honestly, PT block is probably my single favorite block, because the bottom of the foot is just a pain. And we have so many kids that have injuries there. And if you think about the area you're injecting, right, you're going to go in through like the calf, which is not a particularly sensitive area. So we're really like just a little bit of freezy spray right at the skin, and you go in, it's a single injection. I don't even inject local at the skin level. I just go right to the nerve, because I'm doing with a 27 gauge needle. Like once you pierce the skin, it's done. And you get such good anesthesia from, or I guess analgesia, in areas that really can be challenging. So it's a great place to start.
And as you're infiltrating, Matt, are you putting a lot through the tract, kind of from skin downwards, as you would with local little bits, or?
Usually I'm just going, because I'm just like, if I'm doing these, I'm usually just going straight to the nerve and injecting right there, and the track I actually don't even touch. I just take the nerve out. Because again, like if I'm basically, the pain of going into the track has already happened, and once the needle's gone, like it's nothing. Now, if I'm doing a block needle, the blunt tip needles, those you need to do a little skin wheel, because the needle itself, has to kind of ram through the skin, since it doesn't have a cutting tip on it, and that would feel uncomfortable. So those I'll do like a cc or two of lidocaine right at the skin level, and then go through the block needle. But again, having had them done on myself, those, it's at that point, all I feel is pressure. Like it's just a little pressure, and you can actually feel the pop of like fascial planes and going through the skin. But it's not even like painful. I would by not any means consider myself to be someone who has like, like one of those like I have a high pain threshold sort of things. It's just not particularly painful. These are, especially the hypodermic, it's a smaller needle than you're using for IVs. Like that 27 gauge is teeny tiny.
Yeah, agree. It must be very powerful, you being able to tell the children and the carers that you've had this done on you that day, or yesterday, or the day before. That is very good.
Yeah, there's sometimes explaining to do when I have a bunch of band-aids on my arms.
It's good. You're struggling to breathe from your sort of core trunk blocks. Yeah. Any other questions for Matt before we wrap up? I just want to say a massive thank you, because it's been great. Ooh, that's raised. No, I was going to give you a thumbs up. It's been great having someone with so much experience to talk to us in this group. Hopefully we'll get Matt back again in 2025.
I will add just one clarifier. When my fellows are blocking me, they're blocking me with saline. I'm not.
Yes.
I'm very rarely being numbed up. Like they've done bilateral femorals on me before, so I wouldn't be able to walk.
Wow.
The one time I did my saphenous, I actually did anesthetic, which I didn't think it was working right, and I just kept pinching myself. I'm like, I still feel something, and the next day, like my entire medial leg was bruised because I've been pinching myself so hard to make myself feel it. So that one is the one time I actually put anesthetic in.
Wow, powerful stuff. So yes, thanks again. It sounds like everyone's really appreciated you coming to share your wisdom with us. So we'll get you back in 2025 if you'll come.
Yep, sounds good.
And I think getting 42 people a day in the middle of December has been pretty good as well. So that's awesome.
Yep. Appreciate it. Feel free to reach out with questions, and hopefully some of those resources will be good for folks going forward.
And guys, if anyone wants to talk next year, do a little literature review. It doesn't have to be anything big. You know, you can look into a small topic. You're very welcome to plan to do a talk for us next year. So give us a shout. And take care, everybody, and Merry Christmas.
Merry Christmas and Happy New Year's. See you guys.